Okay. So hello, my name is George Minawata, and I'm a volunteer pulmonologist for the MAVEN Project. Thank you all for attending and being part of the MAVEN Project. I especially want to thank our friends and partners at Clinica Sierra Vista, who serve the communities of the Southern Joaquin, also known as the Central Valley in California, one of the most productive agricultural areas in the world, for hosting today's session. Before I turn over the mic to our speaker, Dr. Charles Schulman, let me tell you a little bit about him. Dr. Schulman recently retired from active practice as a non-invasive cardiologist after 53 years, but he continues to teach and consult. He is a senior physician emeritus at the Beth Israel Deaconess Medical Center in Boston. He's published numerous scientific articles and abstracts that have appeared in the New England Journal of Medicine, Circulation, the American Journal of Cardiology, and the British Heart Journal. His research interests include the treatment of hypertension, congestive heart failure, and hyperlipidemia. And with that, Dr. Schulman, the mic is yours.
Thank you, George, and good afternoon, everybody. Welcome to our webinar. We will talk about hypertension this afternoon. Project can issue CME credits, and my disclosure and the disclosure of anybody who's got anything to do with this program is that we have no conflicts of interest. As I say, the MAVEN Project is accredited, and we'll give 1 hour of Category 1 credit for this talk. So to start out talking about hypertension, we should go back to the olden days. Look at President Franklin Delano Roosevelt and his blood pressure. As you can see here, from 1937 to 1944, he had very significant blood pressure, 188, systolic pressure of 188 in 1941, rising to a systolic pressure of 240 over 130 in 1944. At that time, he also had heart failure and was treated with digitalis. He was working 4 hours a day at that time, but he subsequently died suddenly on April the 13th of 1945 due to a cerebral hemorrhage. The doctors were, quote, surprised, end quote. The president's physician said it, quote, came out of a clear sky. There was no indication of imminent danger. We know better than that today. So we've come a long way in diagnosing and in treating hypertension. So the learning objectives for this activity are that you should be able to use proper technique when measuring blood pressure. You should be familiar with blood pressure goals and implement a strategy for both initial and subsequent, both non-pharmacologic and pharmacologic management, and recognize when to look for secondary drivers of hypertension and causes, and secondary drivers of and causes of hypertension, like hyperaldosteronism. Hypertension is obviously a common problem. It's a pervasive problem. It's estimated that 122 million people in the United States have hypertension, and that 3 out of 4 of them are not controlled. In 2021, the last year this data is available, there were 124,508 deaths in the United States with hypertension listed as a primary cause. And obviously, it's a great cost to all of this illness. The prevalence of hypertension goes up as we age, so that, 30s and 40s, the incidence of hypertension is somewhere between 32 and 46% of the population. By the time you get to age 65, 70 in the 70s percent of the population, male and female, have hypertension, and over the age of 75, 80% of people have hypertension. This is an old study published in 2002, a meta-analysis of 61 studies involving 11 million, involving 1 million adults, cooperative study from the hypertension study groups. And it relates age and blood pressure to ischemic heart disease mortality. You'll notice that there are a series of curves. This is systolic, this is diastolic. And there are a series of curves at each age group. So as your age goes up, your blood pressure goes up, and your risk goes up. And as your blood pressure goes up, your risk goes up. There's an association between blood pressure and other cardiovascular disease risk, not only cardiovascular disease mortality, but stroke, coronary heart disease, and myocardial infarction. And that risk increases with increasing blood pressure. So going from normal to elevated to outright hypertension raises the risk. Now I'm going to show you two trials. This is really a pivotal landmark trial, the SPRINT trial, an NIH trial that introduced the idea of intensive blood pressure treatment. So the purpose of this randomized controlled trial was to examine the effect of an intensive blood pressure treatment versus a standard blood pressure treatment. The standard blood pressure goal being a systolic goal being under 140 millimeters of mercury. The intensive treatment group aimed for a systolic pressure of under 120. 4,600 plus people in each group. There were 35% females, 28% of people over the age of 75, and 30% African Americans. The primary outcome was a composite of myocardial infarction, acute coronary syndrome, stroke, heart failure, or death from cardiovascular disease. And the results were strikingly positive. In the overall group, there was a 25% reduction in all-cause mortality. And in the primary outcome, as listed on the page prior, okay, with a strikingly positive p-value. In the people over the age of 75 in this study, the results were even better, with a 34% reduction. So it's clear that intensive treatment benefits the patients. Adverse effects, of course, happen, and the two important ones for people over the age of 75 were hypotension and ureus falls. The other trials are much more recent one that essentially shows the same thing. This was a group from a study from China, 8,500 people between the ages of 60 and 80, randomized to standardized treatment of 140 to 150 systolic blood pressure, and an intensive treatment of 110 to under 130. And the results are very similar, 26% reduction in the positive, in the primary outcome. So this really shows the same kind of result in an updated study. So there are three questions to ask when your patient comes in to have his or her blood pressure measured. Were you rushing to get here, or were you physically active, Or did you have a cigarette right before this appointment? Have you been taking your medicine? That's going to turn out to be a extremely important part of blood pressure treatment, and I will talk about that again and again. What's your diet and physical activity regimen like? So then we measure the patient's blood pressure. And so here's a picture of a medical assistant measuring the blood pressure of a patient, but there's something wrong with what's wrong with this picture. Put your answers in the chat. You correctly pointed out that his legs are crossed and he's drinking coffee. This is the correct technique. Okay. Patient should empty his bladder, should be sitting in a chair with his back supported, feet on the ground, legs not crossed. The blood pressure arm should be about but positioned in such a way that the cuff is about heart level. No talking. And the cuff should be on bare arm, not over clothing. So in 2017, which is now 7 years ago, the American College of Cardiology and American Heart Association issued guidelines for the prevention, detection, evaluation, and management of high blood pressure in adults. Previously, there was something called the Joint National Committee that did the same thing, but they basically went out of business and gave up issuing these guidelines. And so ACC and AHA took over that task. And this just shows the differences in blood pressure classification between 2003 and 2017. So in either case, 120 over 80 is normal. In the previous guidelines, 120 to 140 systolic and 80 to 89 diastolic was called pre-hypertension, and hypertension was defined as blood pressure over 140 over 90. In the new guidelines, based at least in part on the SPRINT trial, blood pressures between 120 and 129 are called elevated blood pressure, and hypertension is defined as a blood pressure greater than 130 systolic. Okay, so the definition of high blood pressure is blood pressure greater than 130 over 80. That's the definition. And it's also the goal. Now, turning to some non-pharmacologic aspects of treatment of hypertension, there are two things that we have to consider before we get to other forms of treatment. One is salt intake. Okay, high dietary sodium raises blood pressure. The mean sodium intake in the United States is estimated to be between 2,300 milligrams and 4,700 milligrams a day. And limiting salt intake lowers blood pressure and reduces extracellular fluid volume. The results are more prominent or more, they're better with greater blood pressure lowering from limiting salt intake in hypertension and resistant hypertension than in pre-hypertension. Okay. This considers African American and non-African American subjects in this study. And you see that the higher your pressure, the more likely it is that you'll get a benefit from limiting salt intake. And that leads us to today's first quiz question. Which has more sodium? 1 Hebrew National Franc or 11.5 ounces of V8 juice? Put your answers in the chat. It's for V8. And you're right. It's the V8 juice. The B Frank has 480 milligrams of sodium. The juice has 920 milligrams of sodium. Which has more sodium? 1 Panera Bread Southwest Caesar salad with chicken or a slice of Domino's pizza? Pepperoni pizza, I ought to say. Okay, answers in the chat. Sarah's right. That beef frank doesn't seem very healthy either. Okay, everybody is going with the pizza, except Greg, who says have to go with the pizza, but probably the other one. Well, yeah, you have to decide, Greg. Most votes were for the pizza, and the answer is the salad. The Panera Bread Southwest Caesar salad with chicken has 1,070 milligrams of sodium. All right, so there's a gram of sodium in that one salad. The pizza only has 830 milligrams of sodium. Okay, I think this is the last one. Which has more sodium? 1 burrito, 1 Chipotle burrito with rice, beans, etc., or 1 Olive Garden chicken marsala fettuccine entree. Who votes for Olive Garden? It's voting. More for Olive Garden. Okay, and the answer is the burrito. Not that the pasta has low salt, right? The pasta has 2,580 milligrams of sodium. That's more than a day's allotment should be in one meal. But the burrito has even more. So the AHA has named this what they call the salty six: bread and rolls, pizza, sandwiches, cold cuts and cured meats. That would include the hot dogs, canned soup, especially canned soup. Read the labels. Go to any supermarket or even an upscale supermarket and look at the nutrition content of their soup. You'll see how much salt there is in their burritos and tacos. And, this shows just where people's salt comes from. Much of it from processed foods from the grocery store. So what are some strategies for sodium reduction? Okay, at home, avoid processed foods sold in cans, boxes, and jars. Read food labels. Read labels. Buy low sodium versions of food. Stick to fresh foods. Cook without salt. Try fresh turkey, chicken, and lean beef instead of cured and smoked foods like bacon, sausage, and lunch meats. And try to eat at restaurants less often. And when you do, ask for low sodium dishes. Okay, we were at a Japanese restaurant not too long ago, and they had edamame, which came out loaded with extra salt put on it. So all you need to do is ask them not to put salt on it. That's the idea. Now, another aspect of hypertension production is the role of aldosterone. Okay, aldosterone causes an upregulation of angiotensin II receptors and a potentiation of the pressor responses to angiotensin II, leading to sodium retention and volume expansion. So with increased aldosterone production, you get increased retention of sodium, increased serum sodium, increased excretion of potassium, low serum potassium, and hypotension. The hypokalemia is a clue, but many people will have aspects of hyperaldosteronism contributing to their blood pressure, and the response to something like spironolactone will depend on how much the aldosterone is contributing to that person's blood pressure. If it's small, then the aldosterone won't do a lot. If it's a large contribution, the results may be very dramatic. Here are some early markers of hypertensive cardiovascular disease. It used to be called end organ damage, but we're talking about the same thing. So in terms of blood pressure, an exaggerated blood pressure response to exercise on a stress test. A woman's blood pressure reaches over 190, men over 210 on a stress test. Even if their pressure was normal at rest, that's not normal. That's an exaggerated blood pressure response. Then there's the loss of the nocturnal dip. People being called dippers and non-dippers is a British way of addressing the problem. Catecholamines and blood pressure and pulse rate have a circadian variation. So it's low in the middle of the night, rises first thing in the morning. This presumes that you're on a normal schedule. If you work nights, it's going to be different. But during the day, your blood pressure is up, catecholamines are up, and then they fall in the evening, 10 o'clock to midnight, and the lowest levels are something like 4 to 6 in the morning. Okay, so there are what the British call dippers and non-dippers. So this would be a dipper, its blood pressure falls 4 to 6 in the morning, and this would be a non-dipper where it doesn't fall at all. A particularly good example of that would be in people with sleep apnea, whose blood pressures don't fall and whose sleep apnea contributes to their blood pressure. Okay, so here are some other early markers of hypertensive cardiovascular disease: left ventricular hypertrophy, either on an ECG or on an echo, so-called DDD, the DRID diastolic dysfunction, reduced diastolic relaxation, and coronary artery calcium. Coronary artery calcium is a manifestation of coronary artery disease. If you have calcium in your coronary arteries, you have coronary artery disease. Vascular manifestation would be increased carotid INT. Renal manifestations would be microalbuminuria, and increased serum creatinine would reduce eGFR. And in the eye, retinal artery changes. So turning to treatment, see that this is a list of non-pharmacologic interventions. Okay, weight loss, very important. For every kilogram of weight loss, there's a millimeter of mercury reduction in blood pressure. The DASH dietary pattern, which is a diet rich in fruits, vegetables, and is low in fat, the Mediterranean diet is similar. Reduction in dietary sodium. I talked about that a minute ago. The optimal goal might be under 1,500 milligrams a day, but if you can get people to eat to under two grams a day, 2,000 milligrams a day, I think you're doing a good job, and see that you can have. It's like a drug. 6 millimeters of mercury blood pressure lower. Increases in dietary potassium, increase in physical fitness, physical activity. Okay? So, what the guidelines recommend somewhere between 90 and 150 minutes of aerobic exercise every week, and you can have blood pressures lower by 5 to 8 millimeters of mercury. Moderate your alcohol consumption. Men less than 2 drinks, of women a day. Women less than 1 drink a day. If you drink at least 3, it's very difficult to control blood pressure. And using CPAP for sleep apnea, more than 4 hours a day has been shown to lower overall blood pressure about 5 millimeters of mercury, and nighttime blood pressure 7 millimeters of mercury. Just on the subject of weight loss, here are 2 studies. One with a 5-year follow-up of bariatric surgery, showing that after 5 years with a weight loss of 55 pounds, half of the people no longer needed blood pressure medicine. And this is the use of one of the GLP-1 agonists, tirzepatide, in a 36-week follow-up. Blood pressures dropped along with weight. So here are the physical activity guidelines. Emphasize that people should move more and sit less. That any activity has health benefits. Everything counts. The goal is about 150 minutes a week, half an hour, 5 days a week. And as you all know, physical activity helps prevent 8 types of cancer, reduces the risk of dementia, reduces all-cause mortality, heart disease, stroke, high blood pressure, type 2 diabetes, and depression. And it improves bone health, physical function, and quality of life. For older adults, it also reduces the risk of falls and injuries from falls. So I'm accustomed to writing what I call the exercise prescription, which I would write on a prescription pad when we use prescription pads. Of course, we don't use those anymore. The exercise prescription consists of frequency, at least 3 times a week, but more is better. Intensity, and moderately hard, brisk but comfortable. You have to know that you're exercising. Even if walking, you don't want to, right? Going in and out of stores in the mall doesn't cut it. On the other hand, there are mall walkers who walk up and down the corridors early in the morning, and that's perfectly fine. Duration about 30 to 45 minutes with an appropriate warm-up and cool down. So now we turn to the hypertension guidelines and treatment thresholds in terms of non-pharmacologic and pharmacologic treatment, drug treatment. Okay, and the concept here is that when you apply the most vigorous therapy to the people with the highest risk, where there is more of a benefit. So for low-risk individuals with an estimated cardiovascular disease risk based on the pooled cohort equations, with blood pressures between 120 and 129, emphasize a healthy lifestyle. If that patient has stage 1 hypertension, 130 to 139, intensify lifestyle modifications and begin treatment when the blood pressure hits 140. On the other hand, for people who are at higher risk, 10-year risk greater than 10%, diabetes, chronic kidney disease, begin therapy at a blood pressure of 130 rather than 140. Okay. The treatment target is a blood pressure of 130. Oops. Now, these are some major findings since 2017, and I'm not going to read them all, but this emphasizes home blood pressure measuring. All adults with difficult to control or resistant hypertension should be screened for primary aldosterone. I'm going to say that again a little later. Treat young people because they have an earlier onset of cardiovascular disease events. Lifestyle modification not only helps blood pressure, but it improves the effectiveness of pharmacologic therapy. Okay, intensive blood pressure control is not associated with increased hospitalization or the risk of orthostatic hypotension, and asymptomatic orthostatic hypotension is not associated with higher risk of cardiovascular events, syncope, falls, etc. So it's not a reason to withdraw therapy. It may be a reason to reduce therapy. But you see how people make out depends on what the blood pressure is and what symptoms they have at the blood pressure. So this is one good reason. One good reason to do postural vital signs, right? Lying, sitting, standing, to see or to evaluate that. For older adults with hypertension, intensive blood pressure lowering may reduce, partially arrest cognitive decline. There's some evidence to that. And the final item is that multi-level, multi-component implementation strategies, including team-based care, are the most effective methods of blood pressure control in hypertensive patients. We want to utilize all of the resources that we have. So, what therapy should you use? Remember that the major determinant of cardiovascular risk reduction is not which medicine you use, but it's the amount of blood pressure reduction and the blood pressure achieved, with a few exceptions. But overall, it depends on where, the end result, so to speak, as opposed to which medicines you use. None of the medicines are, quote, cardioprotective. In the accomplished trial, an ACE inhibitor and a CCB led to fewer events than an ACE inhibitor with diuretics. So that's one exception. And patients may have comorbid conditions that have non-blood pressure indications for certain medicines, like heart failure or diabetes, having an indication for ACE inhibitor ARB, atrial fibrillation having an indication for AV nodal blocking drugs, and HFpEF, heart failure with preserved ejection fraction, an indication for mineralocorticoid receptor antagonist, spironolactone. With each class of antihypertensive agents, these were all studied, way back when. There was a good blood pressure response in something like 30 to 50% of patients. And if the first one didn't work, the second one would have about the same results. This is a follow-up study of the ALLHAT trial. The ALLHAT trial was one of the trials that that preceded the JNC7 in 2003. And so this is a 23-year follow-up, and you see that their randomized groups had no difference in the cumulative probability of cardiovascular disease mortality. The drugs that were used were clothalidone and lisinopril. So here's the approach. Is the systolic pressure greater than 20/10 above goal? If not, is there proteinuria? If not, initiate an ACE or a CCB, a dihydropyridine CCB. If the blood pressure remains uncontrolled, combine. If the patient does have proteinuria, start with an ACE inhibitor, not the CCB. If the blood pressure is controlled, add the other one. If the pressure is greater than 20, the recommendations are to start with 2 drugs at the same time. Combination therapy if you can use it. And then, with all of these, if the pressure remains uncontrolled, add a thiazide-like diuretic. Reassess soon. Don't let things go 3 to 6 months. You'll never get control that way. And avoid therapeutic inertia, right? Patient comes in, the pressure is too high, and you don't change anything. Now you may not change anything because you want the patient to agree to take his own blood pressure at home. The patient insists that his blood pressure is better at home. Okay, prove it. Right? Record it and bring it in so I can see it. Right? Combination therapy, two smaller doses of 2 drugs is probably better than a max dose of 1 medicine. So instead of pushing the first medicine to its max, add a second medicine at a lower dose. The most common causes of lack of response are medication non-adherence, great big red flag, and people overestimate what they take. There have been studies where drug levels in the urine were checked. I attended a case conference at Beth Israel Deaconess Medical Center this past Tuesday on resistant hypertension, and the patient had blood pressures that were in the 180s all the time, despite 3 or 4 medicines. She insisted that she was taking her medicine. She insisted that she got all of her medicine from the same pharmacy. And pharmacy records were available, medical record. So they were checked. And lo and behold, it turned out that she hadn't taken spironolactone for 2 years. Okay, now, either nobody checked, nobody asked her, they just looked at the record and said, "Oh, this is what you're on," or she lied. So, this is a biggie. This is really a biggie. There may be white coat effect. Blood pressure is higher in the office than it is at home, and there may be improper blood pressure measurement. This just shows that indapamide and chlorothalidone are better blood pressure lowering medicines than hydrochlorothiazide. This shows that there's cardiovascular protection. That's been questioned, so I wouldn't count on it, but they are better at lowering blood pressure, that's for sure. These are the recommendations for diabetics from the American Diabetes Association in their Standards of Diabetes Care, most recent issue, January of 2024. Okay, so if the initial blood pressure is between 130 and 50, start 1 agent. If it's over 150, start 2 agents, right? So over 150, over 90 would be greater than 20 or 10 above goal, right? In any case, lifestyle management, and then again, depending on whether the patient has albuminuria or coronary disease, which drugs you start. The blood pressure goal is under 130/80. That's the goal. The goal is the same for diabetics as it is for non-diabetics. Okay, so assess the blood pressure control and adverse effects. If the treatment is tolerated, continue it. If you don't meet the target, add an agent from a complementary class, or consider changing, and so forth. Consider adding spironolactone at this point. What are some of the secondary drivers of hypertension? Kidney disease, medications like the biggest culprit here are NSAIDs, because people take them and they don't tell you about it. ADHD meds, stimulants, sleep apnea, and primary hyperaldosteronism. So look for it when patients have severe or resistant hypertension, and or hypokalemia, and or sleep apnea, and or atrial fibrillation, which has no apparent other cause. Resistant hypertension. High blood pressure, despite 3 or more drugs. That's the definition. All right. But first, you have to exclude certain conditions before you make that diagnosis. Exclude secondary hypertension, hypertension caused by other drugs or diseases. Pseudo-resistance, again, lack of adherence, or blood pressure medication. Poor blood pressure measurement. Masked hypertension is normal pressures in the clinic and high blood pressures at home. White coat hypertension is high blood pressures in the clinic and normal blood pressures at home. So, how do you manage this? In similar fashion. Exclude other causes, exclude medication non-adherence, ensure a low sodium diet, and maximize lifestyle interventions. Then optimize the 3-drug regimen. One drug from a different class. So an angiotensin blocker, CCB, and diuretic at maximum or maximally tolerated dose. If the blood pressure is still not at target, consider changing the hydrochlorothiazide to chlorthalidone or indapamide. Okay. Blood pressure is still not at target, try spironolactone or eplerenone. Eplerenone is the same as spironolactone, except it doesn't cause gynecomastia. Still not a target. Now add a beta blocker. So beta blockers are like a 4th-line drug in hypertension. Still not a target. Add hydralazine or substitute minoxidil. Here's a situation that's common in the clinic. This is a 53-year-old asymptomatic Bahamian, really Caribbean African, a man of African descent with hypertension and type 2 diabetes, who moved to Florida. Was seen in one of our clinics. His history is that of hypertension, for which he was treated with valsartan, hydrochlorothiazide, and naltepine. But since he came to the United States 2 months ago, he hasn't taken his hasn't taken his medicines. And his A1C was 10.2. His blood pressure in the clinic was 226/134. His exam was otherwise normal, and he had no symptoms. No symptoms. So what should you do? 1, send him to the ER for a hypertensive emergency. Order an ECG, basic labs, order an echo looking for a left ventricular hypertrophy, order a nuclear stress test, restart his meds, and follow up in 2 weeks. Put your answers in the chat. Here's point is, don't send them to the emergency room for a hypertensive emergency, because this is not a hypertensive emergency. These are hypertensive emergencies. A blood pressure greater than 180 with one or more of the following: hypertensive encephalopathy, cerebral hemorrhage, a stroke, acute MI, acute left ventricular failure, unstable angina, dissecting aneurysm, acute renal failure, or eclampsia. So he doesn't have any of those. Yes, I would order an ECG and basic labs. In this fellow, I would also order an echo looking for LVH. I would not order a nuclear stress test because he has no symptoms. Well, you're not going to, basically not going to change anything with a positive stress test. And yes, restart his meds and follow. So my approach to blood pressure goals is as follows. Don't let controversies about blood pressure goals keep you from initiating treatment. Okay, people have said that don't just treat these folks. Treat. Don't let the patient try to talk you into not treating because, quote, I've always had high blood pressure. I use a stepwise approach, aim for a systolic pressure of under 140. If you can do that without adverse effects, keep going. Smaller doses of 2 drugs may be more effective than pushing 1 drug to max. I've said that already. And don't let therapeutic inertia keep you from changing or up to meds. Okay. So, right, it's important to improve adherence. Having said that was one of the key issues. Educate and counsel your patients using motivational interview. Try to simplify regimens when you can. Use fixed dose combination pills where possible. Encourage self-monitoring of home blood pressure. That all the time. Replace 30-day prescriptions with 90-day refills, and use all of the members of your team and telehealth strategies in order to lower blood pressure. And so I'll close with this from a talk that Roger Blumenthal gave on primary prevention. He runs the Johns Hopkins Center for Prevention. Right? 120 is the new 140. Lifestyle modification first. High risk, add meds at 130. Low risk, add meds at 140. Short and sweet. And the doctor is saying to this patient, to prevent a heart attack, take 1 aspirin every day. Take it out for a run, then take it to the gym, then take it for a bike ride. Thank you very much. To entertain questions, and I think I saw some in the chat.
Thanks, Dr. Schulman. There's one question so far in the chat. How often does with orthostatic hypotension and how low a systolic blood pressure would you feel comfortable when treating hypertension? Oh, Dr. Schulman, can you get closer to the mic? We can't hear you.
Okay,
Right,
sorry.
thanks.
Okay. Blood pressure's close to 100 is a place to back off. especially if it's symptomatic. But if the blood pressure, if blood pressures don't go below, 105 or 110, and the patient has no symptoms, then I would be very, very comfortable with that. Okay, let's see, there's another question.
The use of loop diuretics, do you ever use them or consider them for hypertension treatment?
I do in patients who have chronic kidney disease. So if you're going to use a diuretic, I would use a thiazide type diuretic, hydrochlorothiazide, preferably chlorothalidone or indapamide. However, if the BUN creatinine go up, or you get into, well, then you may need to use a loop diuretic. Loop diuretics aren't as good for blood pressure management as they are for heart failure symptoms.
There's another question in the Q&A. So for the case study that you just reviewed, in the, I think it's the clinic at Sierra Vista, to get an echo, you have to put in a referral. It's costly for the patient. How important would it be for that patient, the Bahamian patient who's asymptomatic with that elevated blood pressure? Is it something you can wait on? And
Yeah,
I guess the issue is, like, what would you do? All right, they have LVH on the echo. Is it really going to change your management?
Not really. Not really. It's going to make you make you intensify your treatment, though. You're going to be more cognizant of getting the blood pressure down and keeping it low. But is it going to change which drugs you use? Only if the ejection fraction is less than 40.
Okay.
Patient with a wide blood pressure with diastolic as low as 40 to 50 with isolated systolic pressure, do you have any specific approach, especially in the elderly? Get the systolic. I treat the systolic pressure, not the diastolic pressure in that setting.
And
How do you handle diet control in older patients with limited intake? Does that mean limited funds, or does that mean they're not? Sorry, I mean sodium intake. Well, if the patient is not ingesting a lot of sodium, then opt for something like the DASH dietary pattern, or the Mediterranean diet, emphasizing fruits and vegetables, nuts, and staying away from red meat.
I've got a question around the alcohol, guidance. So is moderate alcohol, however, there's, I guess, is moderation is defined today as, you indicated it'll drop blood pressure, 5-6 points. But is that from, what's the baseline? Someone who drinks more than that?
Yes.
With someone who doesn't drink any alcohol, is this suggestion that drinking a little bit of alcohol would drop their blood pressure?
Yeah, no. It's compared to people who drink more than that.
Okay. Thanks. And then I've got a bit of a, I don't know, it's more a comment than anything else.